All right, everyone. This week we are talking about somatic symptom and related disorders, as well as sleep-wake disorders. So with somatic symptom and related disorders, it's important to highlight and I think recognize that it's relatively not likely that we would be the first point of contact for a person who is who may be a candidate for a somatic symptom disorder, because it's usually physical ailment. So they would be much less likely to come to the conclusion that it's psychological as opposed to physiological. So all of the disorders in the somatic symptom and related disorders share a common feature that the prominence of somatic symptoms are associated with significant distress and impairment. So it is important that you are in close collaboration with medical personnel, because like I said, they would likely be the first point of contact. So the first one that we will cover is somatic symptom disorder. The screening question here would be, are you consumed by worries about your health? And so the diagnosis for this would be made on positive symptoms and signs. So these things that are present, such as distressing somatic symptoms, plus abnormal thoughts, feelings, and behaviors in response to these symptoms, rather than the absence of a medical explanation for somatic symptoms. So you're looking for positive symptoms as opposed to an absence of an explanation for what they're going through. So somatic symptom disorder, like the next disorder that we will cover, is a construct of the previous diagnosis of hypochondriasis. So if you ever, I think we use this pretty pejoratively in our society of like, oh, they're just a hypochondriac, they're worried about everything. Like this is a legitimate fear in many people. So the first criteria here is one or more somatic symptoms that are distressing or result in significant disruption of daily life. So again, these are things that are perceived to be physical ailments. And then second criterion here is excessive thoughts, feelings, or behaviors related to these symptoms or associated health concerns as manifested by at least one of the following: having a disproportionate or persistent thought about the seriousness of one's symptoms, a persistently high level anxiety about health or symptoms, excessive time or energy devoted to these symptoms or health concerns. And then although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent. So again, typically more than 6 months. And then there are levels of severity to this. Mild is having only one of the symptoms specified in criterion B of these 3 symptoms right here. Moderate is 2, and then severe is 2 or more of, moderate is 2 or more fulfilled here, and then severe is 2 or more of these fulfilled, plus there are multiple somatic complaints. So, multiple physical concerns. So illness, anxiety disorder is the other kind of construct as somatic symptom disorder of hypochondriasis. First criteria here is a preoccupation with having or acquiring a serious illness. So one thing that really came to mind as I was putting this PowerPoint together was being aware, like, for example, there may be an uptick in fear around health and stuff, given that we are in a global pandemic. So just keep, and I think these are hopefully times that we never have to live through again. But it's important to take into consideration, what is going on. So I think many people who may, if this global pandemic were not happening, would potentially meet criteria for this, given how they are acting. But given that there are millions of people who have died from COVID, that they're pretty justified in their fears, especially if they have pre-existing conditions or compromised immune systems. So criteria B is somatic symptoms are not present, or if they are present, only mild in intensity. If another medical condition is present or there is a high risk for developing a medical condition, the preoccupation is clearly excessive or disproportionate. There is a high level of anxiety about health, and the individual is easily alarmed about personal health status. The fourth is the individual performs excessive health-related behaviors, such as repeatedly checking their body for signs of illness, or they exhibit maladaptive avoidance. So they're, not going to the doctor because they, potentially assume that they're going to get really devastating news, or that, their concerns will be confirmed, and that this illness preoccupation has been there for at least 6 months, and the specific illness that is feared may change over that period of time. The illness-related preoccupation is not better explained by a mental disorder like somatic symptom disorder, panic disorder, GAD, body dysmorphic disorder, OCD, delusional disorder, or somatic type. And then here, with illness anxiety disorder, you would specify if they are care seeking. So, probably undergoing lots and lots of tests and procedures, maybe disproportionately to individuals with a similar medical profile, or care avoidant type. So they're have these preoccupations, have these worries, and they never go to the doctor. So we have conversion disorder, also known as functional neurological symptom disorder. Screening question here is, do you ever get paralyzed or lose sensation or have fits? So the criteria here are one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between what is manifesting in the body and then any sort of recognized neurological or medical conditions that would correlate with that symptomology. The symptom or deficit is not better explained by a mental or medical disorder, and the symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, or warrants a medical evaluation. So there must be clinical findings for this diagnosis that show clear evidence of incompatibility with neurological disease. An internal inconsistency at examination is one way to demonstrate incompatibility. For example, demonstrating that physical signs elicited through one examination method are no longer positive when tested a different way. So you may need to look at these things from different angles. It is important to note that the diagnosis of conversion disorder should be based on an overall clinical picture and not just a single clinical finding. So just making sure that you're doing a really holistic and thorough comprehensive check. So another one is psychological factors affecting other medical conditions. The screening question here is, does your psychological state have an influence on how things are going with your medical illness? So there are 3 criteria here. A medical symptom or a condition other than a mental disorder is present. So they are have a diagnosed medical condition. Psychological or behavioral factors adversely affect the medical condition in one of the following ways. So they either influence the course of the medical condition as shown by a close temporal association. So remember, temporal is time association between the psychological factors and the development or exacerbation of or delayed onset recovery from the medical condition. So the factors interfere with the treatment of a medical condition. So something here would be potentially poor adherence to whatever treatment plan was provided to them. The factors constitute additional well-established health risk for the individual. The factors influence the underlying pathophysiology, precipitating or exacerbating symptoms or necessitating medical attention. And the last is that the psychological and behavioral factors in criterion B are not better explained by another mental disorder. So these would be where your rule outs of panic disorder, major depressive disorder, post-traumatic stress disorder. And factitious disorder, the question would be, and I wonder how well this goes, are you making up or exaggerating any of your symptoms? So here, you are, so factitious disorder is for the individual. And then the second here, factitious disorder imposed by another, like I think of the, I don't know if anyone's familiar with this, but kind of the news story of the child that was like wheelchair bound, had so many ailments that claimed to be ailments by the mom. No tests would confirm it of her daughter. And if they came to realize that the daughter actually had nothing wrong with her, but basically since birth, her mom had been essentially convincing her and trying to convince medical professionals that like all of these things were wrong with her. So, but I'll get to that in just a second. So factitious disorder for the individual is the falsification of physical or psychological signs or symptoms or induction of injury or disease associated with identified deception. So as we read in the text, like people who would be injecting feces into their skin to be able to have abscesses and things like that. The individual presents themselves to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards, which is how this is differentiated from, I can't think of the other disorder, malingering. And then the fourth is the behavior is not better explained by another mental disorder, such as delusional disorder or other psychotic disorder. So this diagnosis requires demonstrating that the individual is taking surreptitious actions to misrepresent, simulate, or cause signs or symptoms of illness or injury in the absence of obvious external rewards. Like I said, that's how this difference is different from malingering. So then we have factitious disorder imposed on another previously factitious disorder by proxy in the DSM-4 text revised. So this is the falsification of physical or psychological signs or symptoms or induction of injury or disease in another person associated with the identified deception. The individual presents another individual who would be deemed a victim to others as ill, impaired, or injured, because this is abusive. The deceptive behavior is evidenced even in the absence of obvious external rewards, and the behavior is not better explained by that individual having another mental disorder. So then we are moving to sleep-wake disorders. So the first is insomnia. Question to ask is, do you have trouble sleeping? So the essential feature of this is a dissatisfaction with sleep quantity and quality, with complaints of difficulty initiating or maintaining sleep. So remember, this is subjective. There are some baselines for this because there are people who sleep in spurts and they do not feel tired. So this really has to do with distress. The sleep complaints are accompanied by clinically significant distress or impairment in important areas of that person's life, and the sleep disturbances may occur during the course of another mental disorder, or if they occur during the course of another mental disorder or medical condition, it may occur, they also may occur independently. So this might be something where there's a dual diagnosis. So here, this is where some of that like subjective piece comes in. Symptoms of difficulty falling asleep and difficulty maintaining sleep can be quantified by the individual's retrospective self-report, having them keep sleep diaries, whatever other methods there are. They could have some scans happening while they sleep, but the diagnosis of insomnia disorder is based on the individual's subjective perception of sleep or a caretaker's report. So insomnia, as reported by parents of children. Hypersomnolence is, the question would be, do you have to sleep more than most people? So here, it's a broad diagnostic term and includes symptoms of excessive quantity of sleep, so extended nocturnal sleep or involuntary daytime sleep, deteriorated quality of awakeness, so they have a difficulty staying awake or being alert, sleep inertia, so a period of impaired performance and reduced vigilance during awakening from regular sleep episode or a nap. So here we have 5-6 diagnostic criteria here. Sleep or self-reported excessive sleepiness, despite a main sleep period lasting at least 7 hours with at least one of the following symptoms. So they have recurrent periods of sleep or lapses into sleep within the same day, a prolonged main sleep episode of more than 9 hours per day that is non-restorative, so they don't feel refreshed after they wake up from sleeping that amount of time, difficulty being fully awake after abrupt awakening. So this occurs at least 3 times per week for at least 3 months, and it's accompanied by significant distress or impairment. It's not better explained by and does not occur exclusively during the course of another sleep disorder. some of them that will be, all of them that we'll be covering in future slides. It is not attributable to physiological effects of a substance, and it is coexisting mental or medical disorders do not adequately explain the predominant complaint. So then we'll cover narcolepsy. So first criteria here is recurrent periods of an irrepressible need to sleep, lapsing into sleep or napping occurring within the same day. These must be occurring at least 3 times a week over 3 months. And then we have to have the presence of at least one of the following. So episodes of cataplexy defined as either occurring, defined as either A or B. So cataplexy in individuals with long-standing disease, brief seconds to minutes episodes of sudden bilateral loss of muscle tone with maintained consciousness that are precipitated by laughter or joking. So these symptoms come on after a individual begins laughing. So to be clear, cataplexy, as defined in the bottom, is a sudden loss of muscle tone while a person is awake that leads to weakness, and a loss of voluntary muscle control is often triggered by sudden strong emotions like laughter, fear, anger, stress, or excitement. And then also, the cataplexy can come on in children or in individuals within 6 months of onset, spontaneous grimaces or jaw opening episodes with tongue thrusting or a global hypotonia without any obvious emotional triggers. And then there are some biomedical measures here, and then a nocturnal sleep polysomnography showing rapid eye movement sleep latency less than or equal to 15 minutes, or a multiple sleep latency test showing a mean sleep latency less than or equal to 8 minutes and 2 or more sleep onset REM periods. So these would be obviously where you are, consulting with a sleep expert or somebody who studies this, has the access to these types of measurements. So then there's a group of breathing related sleep disorders. So we'll be covering obstructive sleep apnea, hypopnea, central sleep apnea, and sleep related hypoventilation. So obstructive sleep apnea, do you snore heavily, wake up a lot at night, and then feel tired during the day? So there's evidence of polysomnography of at least 5 obstructive apneas or hypopneas per hour of sleep. And so that's just, so here, just to be clear at the bottom here, apnea refers to a total absence of airflow, and hypopnea refers to a reduction in airflow. So that these happen at least 5 times per hour, and either of the following sleep symptoms, where it's nocturnal breathing disturbances, or there are daytime sleepiness, fatigue, or unrefreshing sleep despite sufficient opportunities to sleep that is not better explained by another mental disorder or a medical condition. So there's evidence by polysomnography of 15 or more obstructive apneas or hypopneas per hour of sleep, regardless of accompanying symptoms. So here on this index, you can have the severity. So these are indexes that you would want to, again, consult with another professional that has expertise and training in this area. Central sleep apnea, it is characterized by repeated episodes of apneas or hypopneas during sleep caused by variability in respiratory effort. These are disorders of ventilatory control in which respiratory events occur in a periodic or intermittent pattern. So you're looking for evidence by polysomnography of 5 or more central apneas per hour, and the disorder is not better explained by another current sleep disorder. The last one is sleep-related hypoventilation. So polysomnography demonstrates episodes of decreased respiration associated with elevated CO2 levels, and the disturbance is not better explained by another sleep disorder. So then we have several circadian rhythm sleep disorders. Largely the question here for all of these would be, do you have a very irregular pattern of sleep? So largely in this subset of sleep disorders. You have a persistent or recurrent pattern of sleep. Oops, sorry, I lost my cursor. Of sleep disruption that is primarily due to an alteration of the circadian system or a misalignment between the endogenous circadian rhythm and the sleep-wake schedule required by an individual's physical environment or social or professional schedule. So we'll talk about things like shift work. And then the second is that the sleep disruption leads to excessive sleepiness or insomnia or both. Third is that the sleep disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And then you should specify between these three if it's episodic. So these symptoms last at least 1 month, but less than 3 months. Persistent is when they last 3 months or longer, and recurrent if there are 2 or more episodes that occur within the space of 1 year. So getting more specific here, circadian rhythm of delayed sleep phase type. So this is primarily based on a history of a delay in timing of the major sleep period, usually more than 2 hours. So this is something that when the person tries to fall asleep that they're unable to, so it's when they want to go to sleep and want to wake up, and then this can result in symptoms of insomnia or excessive sleepiness. And the course is persistent, lasting longer than 3 months with intermittent exacerbations throughout adulthood. Then we have advanced sleep phase type. This may be documented with the specification of familial. So this is something that runs in the family essentially. Although the prevalence of familial advanced sleep phase type has not been established, a family history of advanced sleep phase is present in individuals with advanced sleep phase type. So then we have irregular sleep-wake type. So this is a diagnosis of irregular sleep-wake that is based primarily on a history of symptoms of insomnia at night, during the usual sleep period, and excessive sleepiness or napping during the day. So they may not nap, but they're very tired. Irregular sleep-wake type is characterized by a lack of discernible sleep-wake circadian rhythm. There is no major sleep period, and the sleep is fragmented into at least 3 periods during a 24-hour day. So again, does this also cause distress? So this is the non-24-hour sleep-wake type. It is quite prevalent in individuals who are blind, 50% prevalence. And so this is based primarily on a history of symptoms of insomnia or excessive sleepiness related to abnormal synchronization between the 24-hour light-dark cycle and endogenous circadian rhythm. So endogenous circadian rhythm basically just means that all of us have like a pretty natural circadian cycle, that our sleep patterns don't align with that. And then it can hopefully make some sense that an individual who is not able to see light or dark has difficulty discerning like when those are happening. Individuals typically present with periods of insomnia, excessive sleepiness, or both, which alternate with short asymptomatic periods. So times where they're not sleeping, times where they aren't excessively sleepy. So then we have shift work. So this is primarily based on a history of an individual working outside of it says normal, but I'm going to say like socialized, capitalized 8 a.m. to 6 p.m. daytime window. So this is usually third shifters, those who are working from 7 p.m. to 7 a.m., 11 p.m. to 7 a.m., stuff like that. On a regularly scheduled basis. So they're not doing this, working at night just on like an overtime basis or every once in a while. So symptoms of excessive sleepiness at work and impaired sleep at home on a persistent basis are prominent. So here, the presence of both sets of symptoms are usually required for a diagnosis of shift work type. And then typically when the individual reverts to a day work routine, the symptoms resolve. So now we will talk about parasomnias. So non-rapid eye movement, sleep arousal disorder. So this is something that you can ask questions to the parent or an adult patient. So for a parent who may have a child, does your child walk or talk in their sleep or have sleep terrors? And then for an adult, for themselves, have you been told that you walk or talk in your sleep or have sleep terrors? So here, criteria A, essentially these recurrent sleeps episodes of incomplete awakening from sleep, usually occurring during the first third of a major sleep period. So again, if you fall asleep at 10, wake up at 6 for an 8-hour period, you're looking pretty much within that first 3 hours ish. And then so we categorize these two things into sleepwalking and sleep terrors. So accompanied by either one of those things. So sleepwalking, also remember that this sleepwalking isn't necessarily somebody like going and walking around their house, leaving their bed, leaving their room. This is in stages. So make sure that you take note of that from your readings of like what constitutes sleepwalking. So these are repeated episodes of rising from bed during sleep and walking about. While sleepwalking, the individual has a blank staring face, is relatively unresponsive to the efforts of others to communicate with them, and can be awakened only with great difficulty. So here, there are also two specialized forms of sleepwalking. So sleep-related eating. So this is eating at night, having no memory of this. And then also sexual behavior. So it can be sleepsomnia or sleep sex. Sleepsomnia is usually masturbation, something that's potentially connected to like a sex-related dream, but there's no memory of this. And then sleep sex has actually been, quite a question of criminal activity, of essentially having sex with a unwilling partner, or a partner, maybe they're a willing partner, but it's while you're asleep, you are engaging in sexual activity with another person who may or may not also be asleep. I know that with sleep sex, there's lots of shame, lots of just generally a lot of remorse. And there have been people who have gone to jail and prison for this, and having had no memory of engaging in sleep sex. And then there are sleep terrors. These are recurrent episodes of abrupt terror arousal from sleep, usually beginning with a panicky scream. There's intense fear and signs of automatic arousal, like rapid breathing, sweating, that are relatively unresponsive, where the individual is relatively unresponsive to efforts of others to try to like end the episodes. And then another criteria is no or little, like only single visual scene, dream imagery is recalled. Amnesia for the episodes is present. The episodes cause clinically significant distress or impairment, socially, occupationally, or in other important areas of functioning. I would argue that sleep related sexual behavior causes a lot of relational issues. The disturbance is not attributable to the physiological effects of a substance or a medication. Then coexisting mental and medical disorders do not explain the episodes of sleepwalking or sleep terrors. So then we're going to cover nightmare disorder. The question is, do you suffer from nightmares? So nightmares are typically lengthy, elaborate story-like sequences of dream imagery that seem real and that incite anxiety, fear, or other dysphoric emotions. Nightmare content typically focuses on attempts to avoid or cope with an imminent danger in that nightmare, but may involve themes that evoke other negative emotions. So the criteria here: repeated occurrences of extended, extremely dysphoric and well-remembered dreams that usually involve efforts to avoid threats to survival, security, or physical integrity that generally occur during the second half of a major sleep episode. And then on awakening from these dreams, the individual rapidly becomes oriented and alert. The sleep disturbances causes clinically significant distress and impairment. And this nightmare symptoms are not attributable to physiological effects of a substance or a medication. And that coexisting mental and medical disorders do not adequately explain the predominant complaint of dysphoric dreams. So then we have REM sleep, rapid eye movement, sleep behavior disorder. Have you been told that you do strange things while you are asleep? So here, so those last three criteria, E, F, and G, are pretty standard with all of the sleep-wake disorders. But here for criteria A, it is repeated episodes of arousal during sleep associated with vocalization and or complex motor behaviors. These behaviors arise during REM sleep, so that is a stage of sleep. It's the second deepest stage of sleep. and therefore usually occur more than 90 minutes after sleep onset and more frequent during later portions of sleep period. They're uncommonly occur during daytime naps because we usually don't hit REM in naps. Upon awakening from these episodes, the individual is completely alert, awake, and not confused or disoriented. And then either of the following things are happening: REM sleep without atonia or polysomnographic recording, and a history suggestive of REM sleep behavior disorder and an established, I don't know how to say that, synucleinopathy diagnosis, such as Parkinson's disease or multisystem atrophy. So here, then we're going to cover restless leg syndrome. So this is an urge to move the legs while usually accompanied by or in response to uncomfortable and unpleasant sensations in your legs. So all of the things that I'm about to list will be present here. The urge to move the legs begins or worsens during periods of rest or inactivity. The urge to move the legs is partially or totally relieved by movement. And the urge to move the legs is worse in the evening or at night than during the day, or occurs only in the evening and night. So these 3 symptoms have to occur at least 3 times a week and have persisted for at least 3 months. And then those standard last 3.